and address any clarificatory questions that you might have for the researchers on specific slides, but keep the substantive questions for the Q&A at the end. And so before we get started, I'll just quickly introduce you to the Cash Transfers for Child Health Initiative. So this initiative was set up at JPAL South Asia with the aim of improving child health by generating policy-relevant, rigorous evidence on the design of and delivery of cash transfers and pay-for-performance programs. And we launched this initiative with initially a comprehensive review of existing evidence, identified key research gaps, and since 2016, we funded several scoping pilots and large-scale randomized evaluations to address some of the questions that were identified. So far, Catch has allocated over $2.5 million in funding to various research projects, including 7 full evaluations and several scoping studies. And these studies are primarily with governments in multiple states in India. The initiative is chaired by 2 JPAL affiliates, Pascaline Dupa, who will be speaking later today, and Seema Jayachandran. So today's session, like I mentioned earlier, is on the effects of India's COVID-19 lockdown on non-COVID healthcare seeking. At the start of the pandemic, as an initiative along with our funders, BMGF, we funded a few different studies that were looking at descriptive data collection on how COVID-19 has impacted several indicators. And this presentation today sort of focuses on that area. And this is the final webinar that we have as part of this ongoing series. So before I hand it over to our moderator today, I just wanted to quickly introduce him. So we have Stefan Nachuk, who is currently the country lead for health system design at BMGF in India. And he has designed a strategy in support of Government of India's policy objectives on health system transformation. He has over 20 years of experience in international development program design and management, strategic planning, and team leadership. His areas of technical expertise include health systems, primary healthcare, governance, institutional analysis, poverty reduction, microfinance, and capacity building. He was chief architect and leader of the Joint Learning Network for Universal Healthcare Coverage, as well as the Center for Health Market Innovations. He was also the co-architect of Harnessing Non-State Actors for Better Health for the Poor, a network of donor agencies that work together to address the private sector in health. He has had staff positions with, among others, the World Bank, Rockefeller Foundation, and the University of California, San Francisco. So with that, I'll hand it over to you, Stefan. Thank you.
Okay, thank you very much. This is going to be a great, I think this is really going to be a great session. I won't actually repeat the topic of the session. I think, Urvashi, you've already outlined that nicely in the presentations. We'll get into that. I would just say a couple of things. One is I've always been a huge fan of JPAL. I've always found them doing fascinating work, going back to my World Bank days in Indonesia when Ben Olken started doing work on assessing village small grants programs, national programs under the tutelage of the bank. And just to show you that evaluative tools can be not boring, this included actually building his own road to figure out what it actually cost to build a road. So there was a lot of creativity that can go into this work, and I've always found it fascinating, and I think this will be really interesting too. Just a kind of a quick rundown on timing. We'll have about 50 minutes, give or take, for the 2 presentations. There'll be a little bit of a break to ask clarification questions in the middle. And then roughly 30 minutes, you know, the best laid plans, we never know how it'll go, for Q&A. And we'll be gathering Q&A as we go. And I think there'll be, I assume there's going to be actually quite a bit that'll come out of this. So this is a really interesting topic. Just to introduce the 2 speakers, Pascaline Dupa is a professor of economics at Stanford and has been there since 2011. She focuses on interventions and policies that can help reduce global poverty, a noble calling. And ongoing work right now includes studies of education policy in Ghana, family planning policy in Burkina Faso, digital credit regulation in Malawi, and government subsidized health insurance in India, among other things. She's on the executive committee of JPAL and one of the co-chairs for the health sector and catch initiative, which you just heard outlined. Among other nice things, she's a National Science Foundation Career Award winner, a fellow of the Econometric Society, a former Sloan Fellow, and a current Guggenheim Fellow. That's a lot of awards. Congratulations. And we also have Radhika Jain. She's Asia Health Policy Postdoctoral Fellow at Stanford for 2019 to 2021. She focuses on the role of the private sector in health systems, frictions in healthcare markets, and the incidence of public health policy benefits. She did recently complete her doctorate at a university on the eastern tip of Massachusetts. Use your own imagination. And her dissertation examined the extent to which government subsidies for healthcare under insurance are captured by private hospitals instead of being passed through to patients. I would encourage you to reach out to her. This is a fascinating, fascinating piece of work which has huge policy relevance in India today as the PMJ program rolls out. So I will stop there. I probably said too much and pass it over to you guys because I think you want to hear them, not me.
Sorry about that. It turns out it's hard to unmute yourself once you've shared your screen. So let me try again. Okay, here we go. If you don't hear my, don't see my screen, please tell me. Otherwise, I'm gonna get going. So thank you so much for having us on this webinar series, and thank you so much to everyone for joining. I know it's quite late in India, and many of you are in India, so we really appreciate your time. The work that we'll be talking about today, Radhika and I will be doing the presentation, but I just wanted to mention that obviously we wouldn't have been able to do any of this work without our wonderful team on the ground based at Jayapal South Asia at IFMR. That includes Ambika Chopra, Mustafa Patel, and Putul Gupta, who hopefully are also here listening and are also eager to hear your comments and questions. And the work that we'll be presenting today, as mentioned, was funded by the CASH initiative through initially a grant from the BMGF. And it builds on a partnership that we've had with the health department of the government of Rajasthan for now 5 years. And so before we dive into the details of what we did related to COVID-19, which I know is what's at the top of your mind, the same way it's at the top of ours, I just want to take a couple of minutes to first kind of provide some background on this relationship that we had with the government of Rajasthan, because I think it highlights the good that can come out of the type of partnership that we have and the work that researchers can do to help inform policy. So here's a roadmap for today. I'll provide this brief overview of our partnership with the government of Rajasthan, which is focused for our part on the health insurance scheme that was launched in Rajasthan in 2015 under the name BSBY. And I'm going to try to highlight how much you can do just from leveraging administrative data that come out of this type of schemes, which are not specific to Rajasthan, and so other states could have been and could do similar stuff. And then Radhika will take over and present the details of the two sets of issues that we've been able to look at over the past few months, ever since the COVID-19 crisis started, which is the effects of the lockdown on chronic care patients, and immunization of young children. So some background about our relationship. We've been partnering with the health department of the GOR through a number of engagements over the year, including a study that other Jayapal affiliates are about to launch on urban primary health clinics. If you're interested about the other work that's going on, please reach out to Jayapal South Asia. Our team, so Radhika and I and our team in Jaipur have been focused on what was initially called BSBY, is now called Ayushman Bharat, and I'm not going to go through the rest of the name. I think the acronym is easier for everybody to visualize. And this is, a very large scheme, a state-sponsored health insurance scheme that's covering around 15 million poor households, or over 40 million poor individuals. And as part of the partnership with the GOR, we've been granted access to the what's called the transactions management system data or claims data for this scheme from December 2015, so it's launched to October 2019. Okay, so that's over 6 million claims filed by over 700 hospitals across the states. And so what I just want to take a few minutes doing now is showing you how leveraging this health insurance claims data can really help guide policy design. So a key policy goal of that scheme, that health insurance scheme, is to expand healthcare coverage to the vulnerable, and in particular reduce gender inequality, also obviously to reduce medical debt and to improve health outcomes. And one example of what you can do just with claims data is look at whether the program achieves its goal of reducing gender inequality. When we've tried to do that, and by that I mean a simple analysis of the claims data by gender, we actually found very striking gender gaps in access. And what you can see on this graph, on the x-axis, you have the age group. So we've been people into groups of 10 years. And on the y-axis, you see the share female. And what you see, whether you look at the number of claims or number of transactions, which is like two slightly different concepts but very related, you find that the share female is way below 50%. We've excluded delivery claims from this, since obviously childbirth is something uniquely female. But what's very striking, especially for kids, in between 0 and 10, the share female is below 35%. For for children between 10 and 20, it's just about 40%. For only the childbearing age, you see rates slightly around 50%, and then it starts dipping again for older women. Okay, if we do this graph for tertiary care, which is more expensive, or care at private hospitals, which is deemed to be higher quality by the people themselves, we see even more pronounced gaps. Okay. And then if we look at where women get care, conditional receiving care, we find that female patients get care closer to their home. And so essentially it seems like a lot of the reasons why there is this gap in access is that households are less willing to incur costs, be it time costs or transport costs or financial costs to go to the hospital for female members of the household. Now you may say, well, maybe there's gender imbalance in the population. This absolutely cannot explain these gaps, because what I show you on this graph is the same data as before. These blue little X's are exactly the same data I just showed you on the previous graph, which is the share in the claims data. And then what you see in green is, in red, this circle in red, that's the share female in the population based on the 2011 population census. And so, as you know, there is a gender imbalance in Rajasthan, and the share female is below 50%. It's about 48%. So there is a gender imbalance, but it's way less than what we see in the claims data. And even if we zoom in on the poor, and that's what we do in the green dots, where we look at the NSS surveys, and we can look at the poorest half of the households in the state, we still find that there's a little bit of imbalance, but it's definitely much less than what we see in the claims data. So the gender imbalance in the claims data does not come from gender imbalance in the population. It also does not come from differences in disease incidence. One example you'll see later on when Radhika takes over is that when we look at chronic patients who are on dialysis, these are people with a chronic kidney condition, we have only about 32% of the patients who are female, even though if you look at the share of dialysis patients in many other countries, including the US or France, where I'm from, that share is typically above 50%. So there's no evidence that women are less likely to have a chronic kidney condition. They are just much less likely to get care if they have it. So what we can do, when you see something like that in the data and you see, well, there is a big gap, why are women not getting the care? This program was in part designed to help more women access care. It's supposed to be free at hospital when you go and get served under that scheme. So what's going on? Well, we were able to complement our admin data with phone surveys. because in the claims data, you have the contact information of the patients, in particular their phone number, so you can call them, and then obviously not all 6 million, but we could call, you know, a portion of them, especially women who had given birth under the BSBY scheme, and so they are recorded, and sometimes they go give birth not knowing they are covered by the scheme. And that's exactly what we find. We find that there is very little understanding of the scheme terms, and in particular, there was striking gender gaps in awareness. And so women, often, even if they had received care under BSBY, actually did not even know about the scheme. And so this led us to think that maybe it's important to do an information campaign so that our women are more aware of the benefits of the scheme and better able to advocate for themselves and saying, let's go to the hospital, it's going to be free once we get there. And so we had planned to launch this information campaign RCT, looking at whether targeting women helps diffuse information to women and increase their access to the scheme. Obviously, this was put on hold because of the COVID-19 crisis, but we are hoping to resume this work, you know, maybe in January 2021. So this gender analysis is only one example of the work we've been doing. You know, we can also, with claims data, do something like identifying patient survival rates from claim patterns, and that's something that we're going to be using later on in the presentation. So I'm just going to spend a minute on this. You know, the idea is like if you have, you know, claims data, you can find chronic patients because you can see them show up in the claims, you know, every so often. For chronic kidney patients, they actually come 2-3 times a week to the hospital for care. So you can really see them come, you know, very regularly. And sometimes you see them drop. Some, you know, you see they were coming every week, and suddenly they stop coming. So we ask ourselves, does it mean the patient has died? If that means the patient has died, this is, you know, a very useful thing to know, because that means that we can use the claims data to you know, generate health performance indicators, identify areas where the survival rate of chronic patients is much lower than what we think it should be based on the medical literature, based on, you know, what we know of their other conditions. And so to check that, we did phone surveys again, since we have the phone numbers in the claim data, with some of the patients who had dropped from the claim data. And we could confirm, sadly, that 80% of them had died. That means that if you take the claims data and take all the people who dropped from the claims data, conditional on being a chronic care patient, you can then readjust that to, you know, 80%, and you get a mortality rate. So that's something we're going to be using later on in the presentation, but that's another powerful example of what can be done by leveraging this administrative data. We're also doing some work on the role of reimbursement rates, on the prevalence of out-of-pocket payments under the scheme. If you're interested in all of this, please reach out. We are, you know, in the process of writing all these things up. But the general point really is that by leveraging administrative data that are generated by these, you know, state-run schemes, you can really, you know, hope to increase the efficiency of healthcare expenditures by helping policy decisions being based on evidence. Okay, and the potential here is huge, since, you know, as Stefan mentioned, you know, PMJ is being rolled out. The PMJ program is very similar to the BSBY program in Rajasthan. And so helping, making sure that the implementation and the design follow what we've learned from this is going to be quite useful. So just shout out for our colleagues at the IDEA Lab at JPAL South Asia. They aim to expand the capacity of JPAL South Asia at IFMR to work with other state governments on similar, you know, projects, really helping leverage this administrative data, help state governments you know, make the best use of their data. And so if you're interested, if there are some government partners in the audience, please reach out. We indicated their email on the slide. Okay, so let me wrap up by saying that, you know, having this strong capacity to manage and analyze data also matters for crisis management. Okay, and I don't think I need to tell you what crisis we're going to talk about. I think everybody knows, unless you've been in some sort of like hermit meditation for the last 6 months and you just came out of the cave, you may not know, but otherwise you're all very familiar with the fact that COVID-19 has really completely transformed our lives in many ways. And in the case of India in particular, there was a very strict lockdown, as you all know. And this graph using Google Morbidity data, so this is actually very interesting data that Google is making available to everyone, what we've plotted here is the change in movement relative to a base, which is in like January and February. And you can see the first bar on this graph, the first vertical bar is March 24th, which is when the lockdown was announced. And for those of you who are in India, you will remember it was announced with only a 4-hour notice, and it was very strict. It immediately led to a massive drop in movements, as much as 80% based on this data. There was a little bit of changes over time in how Google codes these different groups of whether people are traveling for retail or work or transit. So, comparing the different lines may not be, the most useful thing to look at. What's really key from this graph is that the lockdown was very severe. It led to very, very big drops in transportation, in traveling, in people's access to many things. And it was lifted on June 1st, but as you can see, things didn't pick up after that. There is still, for example, a 20% lower rate of travel for work, and many of you are still working from home in India, and so just like our Japan South Asia colleagues are, and so you perfectly know why things are not yet back to normal. Okay, so when we look at the effect of the COVID-19 crisis, in India, we're going to actually be focusing on the effect of the lockdown. So when you see this graph, you say, okay, well, to what extent did it prevent people from accessing care? There is a study that came out called the PMJ Policy Brief number 8, very quickly after the lockdown started, that used administrative data, transaction management system data from health insurance schemes from a number of states across the country. And they showed this very striking graph, which is that the claim volumes fell by 64% in the early lockdown phase. So you see the data week by week. They show data for the first 10 weeks, stretching up to mid-May. And obviously the green bars is when the lockdown started. The blue bar is just before. And you see the very striking drop. And just from the claims data, you could document the fact that there was a drop in care. Now, they also look by type of care, and when you look at hemodialysis, which is the same sample we're going to be looking at in the first part of the Radhika's presentation, they don't see that much of a drop. They see only a 6% drop. But for oncology, which is cancer patients, it's a much bigger drop. So we were not able to do this same type of analysis because the claims data we have for Rajasthan only goes until October 2019. So we are missing, the claims data that would allow us to do this type of analysis. But instead, what we could do was capitalize on the phone survey infrastructure that we had to monitor health outcomes. Because what you cannot know from just looking at the graphs on the slides right now is whether this drop in health visits leads to bad health outcomes, or whether these are visits that were not that critical, that are just being pushed to later. And so thanks to the 2019 claims data from the BSY scheme, we were able to identify target study populations, and we have two populations: chronic care patients and households with a child who had an immunization due. Okay, and so we are going to be able to look at, for the chronic care patients, the extent to which the disruptions in care led to higher mortality, which is something that you want to be very concerned about, because dialysis care is a life-saving treatment, and if you don't get dialysis, it's very, very damaging to your health. And so the risk of mortality is extremely, high just from the medical literature. So looking at mortality is very important. And for immunization, that's something that has been talked about a lot around the world, whether COVID-19 is going to set back many countries in terms of preventing them from making headways in immunization as expected. And here we're going to be again using phone data to complement whatever administrative data is available. We were able to do all this because the claims data include phone numbers, also the districts, which allows us to stratify our sampling by district and so be kind of representative at the state level. So I'm going to stop here. I'm going to stop sharing my screen, and Radhika is going to start sharing her screen while we do this little switch in who is sharing screen. If there is any question at this time that have come out, please, I'm happy to answer them. Otherwise, we can go straight into the presentation of the COVID research.
Hi, Pascaline. So there are a couple of clarification questions on the box. So one is the usage of health insurance seems to be particularly poor. Given that, do you expect any selection issues in the admin data itself?
So absolutely. So when we are using the administrative data to be able to sample households to then do phone surveys, we have to take into consideration the fact that not everyone takes up the scheme, and so that you can have two types of selection. You can have people who are well enough that they don't actually need the scheme. They'd rather go to the private hospitals or do something else, or they have a private insurance scheme, and so this would be folks who are on average doing better than the ones we can look at in the claims data. The more concerning type of selection is that those who are really vulnerable, really disadvantaged, and really remote are excluded, and then we are missing them in whatever we do. So essentially, if the picture we were going to paint or that we could see so far was very rosy, I would be like, okay, maybe that's not that useful because we are missing out an important constituency. Since what we find is already pretty striking in terms of gender imbalance, even among the households who can come in terms of outcomes under the lockdown, what Radhika is going to show you. I think it's kind of, you can think of what we're showing as a lower bound on the potential issues to be looked into very carefully by the policymakers.
Great, thank you. And then one more question is asking what was the sample covered by phone surveys?
So for different types of mini studies, we have different samples. So for the gender aspect, we identified women who had given birth between 2017 and 2019 and called those households. And I think we had just about, that was a smaller survey. We had just about 3,000 interviews. And again, because we can only call households who already use the scheme, because we find them in the claims data, it's actually here, especially a lower bound on the lack of awareness. But even among that sample, we find that, maybe 20%, if I recall correctly, understand fully the scheme on average, and this is even lower among women.
Great, thank you. I think in the interest of time, I'll let Radhika move forward with her presentation.
Great, thanks. Can you hear me okay? Or I'm going to assume you can hear me okay unless I hear otherwise. Thanks everyone for joining. As Pascaline said, I'm going to start out by covering our dialysis results. I should say that we were concerned about the effects of some of the lockdowns on critical care, chronic care more generally. Our data allows us to look at dialysis, but we think that some of these effects probably generalize to critical chronic care beyond dialysis. So, as Pascaline said, we have the insurance claims data through the end of October. And so we identified all dialysis patients that were on insurance between August and October. The majority of them had their last claim in October. And the idea was that if you were on dialysis in late last year, you continue needing dialysis every week till for the rest of your life. And so you needed dialysis through the COVID period. Using the phone numbers in the insurance claims data, we conducted phone surveys, and we started this in May 2020 and then did a couple of rounds. We tried very hard to, noting that this is a sort of a really hard time for everybody, we tried very hard to keep the phone surveys short, so they're about 15 to 20 minutes. And the surveys broadly collected data on the patient's demographics, their care-seeking behavior both before the lockdown in March and afterwards in April, as well as morbidity, there's symptoms that they faced, and mortality over time. We also included some sort of open-ended questions where we didn't have numeric coded answers, but just allowed the patient to, or the respondent to speak openly and give us some information about the care-seeking disruptions and health problems that they were facing, to sort of understand things a little bit more depth than a survey would allow. As I mentioned, we did a follow-up round in surveys in July and August to track sort of longer-term outcomes. In addition, we did structured interviews with 15 hospitals, 3 of which were public, to understand supply-side problems at this time. And lastly, we used dialysis claims. Again, Pascaline's described them in depth. We used claims from the previous year, from 2018 into 2019, to create a historical comparison cohort. And I'll come back to this in a minute when I show the results. Also, the study, all of this work was approved by the IRBs at Stanford and IFMR in India. So very quickly, we identified about 3,000 patients. 69% of them were male. Pascaline pointed this out, that overwhelmingly dialysis patients in this program are male, although that's not expected biologically. And they're about 45 years on average. We keep in mind that these, the phone numbers that we have are from October. And so we reached about 83% of these households, which is very high actually, use it for phone numbers using administrative data. And 84% confirmed that they had dialysis patient, and of those final households, 94% consented to the survey. And a large part of this dropout is because people sort of change phone numbers fairly frequently in our context. The final sample is about 2,100 patients. And so just, the characteristics of the people we actually surveyed, 45 years on average and 69% male, which gives you some confidence that the people that we surveyed are quite representative of the overall sample, despite the fact that we had a lot of people not reached successfully. And we also, about 20% of them are scheduled caste or tribe. They have 11 years of education on average. And just sort of, some of the assets that they have, 44% of them have a refrigerator, 51% have a motorcycle, but only 8% have a car and 2% have an air conditioner. And so for those of you, in the Indian context, these are poor households that are eligible for BSBY, but these are not the absolute poorest households in the state. So first I'm gonna show you that we document substantial barriers to dialysis care seeking. This is people, the sort of share of people reporting these various problems in getting their dialysis. 42% of patients reported that they had some problem getting to the hospital due to travel barriers. 23% said they had to switch to a different hospital, possibly because the hospital was closed or refused them service. And 18% of people also said that they just couldn't get to the hospital, that they themselves did not go to seek care at some point because of fear of COVID. And then, there are other 17% also reported that they had difficulty getting their medicines. So there's substantial disruptions to people's care during the time of the lockdown and just after it was announced. This also resulted in about almost doubling of spending per visit between March and April, and a sharp decrease in the number of monthly visits patients had. We also find, these are some of the responses from the open-ended questions that kind of illustrate what was going on. One patient said that the hospital was closed on visits and refused treatment as well. We didn't have a mode of transport to reach hospitals, and so I had to try very hard to arrange one. As a result, I could only get 3 dialysis visits instead of 8, and most patients in our sample go for 2 to 3 visits per week. Another patient says, for getting a treatment that my life depends on, I had to get slips from doctors, permissions from district collectors, stand in long queues. The third patient says, due to the shutdown of public transport, I have now to take my wife to dialysis. Because of that, neither can I work nor can I be with my wife during her visits. And another patient says, the cost of acquiring my dialysis medicines almost doubled as they were not available at my regular pharmacist. My hospital was closed. I had to look everywhere and they were available in limited quantities only. And then from our hospital interviews, hospitals do not report that they turned patients away or refused services, but some reported having to shut down for a while, and many reported substantial staffing and supply shortages. So, there were problems on the supply side, on the hospital side as well. And then, I mentioned that we did a sort of follow-up survey to track longer-term outcomes, and this is just very quickly to show that a lot of these barriers continue even in the last, in the last 2 months. This is data from July and August. These levels are much lower than what I showed you in April, but still 16% of patients said they had some problems getting to the hospital. And 11% said that they had difficulty getting medicines. So these problems persist at this point, well after the lockdown has been released. So what I'm going to show you here is the mortality, our mortality estimates from the surveys. What we did was we started the surveys in May, but we asked about the patient. If we don't rate the patients themselves, we ask if they're a member of their households about when they died and how they died. And the x-axis is months, the y-axis is the probability of death. And this is the probability of death amongst people that remain alive as of that month. So, about 60% of patients who were still alive in December died. And this rate decreased to amongst those still alive in January, 4% died. And you see a sort of steady decrease down to March, where the rate is about 0.2027. And that's to be expected. We're sampling patients from October. The sickest patients tend to die earlier. Also, it's sort of a global phenomenon that new patients die earlier. But what you see is that, a fairly steady decline. The vertical dashed line is the imposition of the lockdown on March 24th. And the sort of really striking result is that April stays sort of flat, but in May, the first full month after of exposure to the lockdown, we see a dramatic increase in mortality amongst dialysis patients up to 0.044. This is a 1.7 percentage point increase between March and May, or 63.6% increase in mortality. And here I'm showing some longer term data through the end of July. I should point out that we're still collecting data for July, but you see some decrease in mortality in the subsequent months, but it still remains high. So then the question is, you may say, well, maybe mortality sort of jumps around anyway. It goes up and down in various months, or you may say maybe there's some seasonal trend, and that explains why mortality in May goes up every year. In other words, what should this curve look like if there had been no lockdown? And the COVID was sort of global. The lockdown was national. We don't have a control group in this study. But what we do is we create a historical comparison cohort, and I'm showing you that in the gray dotted line here. And what this is sort of building on what Pascaline said, we use claims. So we sort of create a similar cohort of people who had a claim between August and October of 2018, and then follow them in the administrative data over time and sort of classify based on the previous work we've done, showing that people, when they drop out of the claims and you no longer observe them, that's 80% of that is death. We basically create a sort of a measure of death for the previous year. For comparison. And it's really striking. In the first few, between December and March, our estimates for 2019 to 2020 very closely track those of the historical cohort, giving us some confidence that this is actually a reasonable comparison. But we see post-lockdown is the historical cohort's mortality declines steadily. It flattens out slightly, but stays sort of downward sloping and shows no uptick. And so, sort of for comparison, if you believe the historical cohort in May is, May 2020 is 1.57 percentage points higher than May in the previous year, which is about a 56% increase in mortality. So far I've shown you, that there's the very specific timing of the uptick in mortality, as well as the fact that, we don't see this in the historical cohort, really, I think provides strong evidence that the uptick in mortality is about the lockdown. I'll come back to that point. I think we look at heterogeneity by a few groups, and I won't get into all of the results here, but a couple that were really striking. One is responded by patient gender, and here you see males and females between December and January sort of track each other very similarly and have the same sort of downward slope. But after the lockdown, there's the uptick in mortality for males is substantially higher than for females. And we've sort of dug into this a little bit. We've looked at sort of the disruptions to care that females and males report. We've looked at their changes in visits, and we don't find any significant difference in between males and females on some of these things. And so it's a bit of a puzzle. Either it's possible that there are effects of the disruption and lockdown that on women that we aren't observing, that we just didn't measure. But what is sort of undoubtable is the substantially larger increase in mortality amongst females. And this is by age group. And here if you look in the pre-lockdown period, this sort of goes back to a point I was making earlier, that sort of sicker patients are likely to die earlier. So the green line is older patients and the orange line is younger patients. And what you see in the pre-lockdown period is that older patients are much more likely to die each month than younger patients. But if you look sort of at the difference between March and May, a really huge share, the spike for younger patients is really, really large. And so which again sort of suggests that it's really about the lockdown. It's not just patients that are sort of, who would have died anyway. This really sort of changed the trajectory of relatively healthy patients within our sample. So yeah, so I was saying earlier, that I think the timing and the sort of comparison with the historical cohort really sort of suggests that this uptick in mortality is about the lockdown. Another piece of evidence that we use is we look at the, for everyone that is alive as of April 1st. So they, not the people who died before the lockdown, but people who were around at the time of the lockdown and exposed to it. And we create an index of care disruptions, and it sort of, I won't get into all of it, but it sort of combines many of the things that I mentioned on an earlier slide about whether you had to switch hospitals or whether the hospital had a closure or whether you had difficulties getting your medicines. And so we combine that into an individual index and standardize it over the sample. And then we look at the association between that index and various outcomes. Morbidity is also an index of health complications that are known to follow the disruption to dialysis care, including things like swelling and breathing difficulty, vomiting, and weakness. And so we standardize that over the sample. And hospitalization is just an indicator for hospitalization, and death is death. And you see that a 1 standard deviation increase in the care disruption index is associated with a 0.1 SD standard deviation increase in morbidity, a 4 percentage point increase in hospitalization, and 2 percentage point increase in death. And if you look, the last row of the table gives you the overall mean. So these, 4 percentage points on 15%, so essentially 15% of the entire sample was hospitalized. So on that, the association with the increase in hospitalization associated with care disruptions is really, really large. And these results look very, very similar if we include all sorts of controls for where you live and your sort of dialysis history and things like that. So I think overall, this really, we find really strong evidence that the lockdown disruptions to people's dialysis care significantly worsened outcomes for patients on dialysis. I've shown you that people report substantial disruptions like travel barriers, fear of COVID, no medicines, hospital closures. We show a very large uptick in mortality in May after a month of the lockdown. There's some decrease in June and July, but it's not offsetting. It's not, it's not lower than we would expect it to be otherwise based on the historical comparison. The historical comparison also makes clear that this uptick in mortality is not due to just general monthly variation or seasonal trends. And we see some heterogeneity in the mortality effects, and in particular that females and young patients experience large and persistently large increases in mortality. And the last piece of evidence is that post-lockdown health outcomes is strongly, or negative post-lockdown health outcomes is strongly associated with care disruptions during the lockdown. And the last thing I wanted to flag was what I said earlier about, these care disruptions decrease, but they persist in July and August. So it's quite possible that, the effects of this will sort of continue to unfold over the next several months. So if there are clarifying questions about the dialysis, if not, we could hold them to the end and for the Q&A section. Okay, I'm gonna take that as a yes, no, and go ahead. So that was, critical chronic care. The second kind of care that we look at is routine care, and particularly child immunization. So, several states, Rajasthan included, shut down immunization efforts around the time of the lockdown. All of them were stopped. So this is in late March. And then more recently, there have been, the government has opened this back up and actually made a big effort to sort of do catch-up immunizations. But there, the evidence that people have used so far to look at this is the HMIS. I forget what that stands for, but it's the government's sort of, public health health management information system. That's right. And using the publicly available HMIS data, we look at the two lines. So here on the x-axis, you have months. The vertical line is the lockdown in March. The y-axis is just sort of it's just changed relative to January of each year. And so you see the green and the blue dotted lines are from the previous 2 years, and relative to January, the trend in immunization is sort of slightly upwards in February and March, suggesting that in general immunizations increase a little bit in March, but they stay sort of above 1. The red dashed line is the data from this year, and you see it starts in January and February look very similar to previous. Well, February looks very similar to previous years. There's no data available at all for March. April looks like its immunizations were 10% of what relative to January, and again May has no data at all. And this data has been used to say that that immunizations have dropped dramatically, and that sort of raised the alarm. And from what we looking at the data more carefully, it's not clear. It looks like a lot of it is actually incomplete. And certainly anything past May is incomplete. As an example, we also looked at births in the data, and we find that births also drop in March and April, which isn't really, it's not really possible for births to drop since those were determined 9 months earlier. So given that the publicly available data is sort of incomplete, we decided to conduct phone surveys. Again, using the insurance claims data to find households that are likely to have a child, we identified households with a child delivery under insurance between January and October of 2019. So they would be turning a year old over these 8-9 months in 2020. So keep in mind that this is, someone raised the question of selection. These are poor households that are eligible for health insurance, government health insurance, but there are also households that use the insurance and delivered at a health facility. So we aren't making a claim that this is going to be representative of the state population, but it's still a large population and one of interest. So we started phone surveys in August 2020 and broadly collected data about the immunizations on their Mamta card, which is their sort of government immunization card, as well as self-reported immunizations if the Mamta card was unavailable. The details of the last immunization, in particular for all households, as a way to check the Mamta card information. As well as disruptions and interactions with healthcare workers. So far, we've covered about 770 households, 860 children. The survey was started in August and is still ongoing. So I should be very clear, these results today are preliminary and not even representative of our entire study, but I think they are interesting. So first we find, again, people do report that their immunizations were disrupted due to the lockdown. Interestingly, the kinds of the disruptions that people report are very different. Here, a much higher share of people say that fear of COVID was the main thing that sort of stopped them from getting immunizations. Nevertheless, we also find that 14% reported that camps were closed, and or the nurse were missing, or or there was a stock out, and 10% reported some sort of travel barriers. And overall, 18% of households also reported missing a vaccination due to the lockdown. But keep in mind, that not all households even know that they're due an immunization. So this may be an underestimate, but what it makes very clear is that even households know that there are disruptions to immunizations, and households were aware of this. So the first thing we sort of decided to look into is just, using the self-reported date of last immunization, just kind of see, when were people getting immunized? And this is for the entire sample. This is just sort of the distribution of the date of last immunization. The x-axis is months in 2020. And what you see is, a lot of kids, we were sort of surprised at this, but a lot of children have been immunized in June and July. So it certainly seems to be the case that immunizations have sort of started up again. You do see not very much density in March and April in particular, although it never, didn't completely stop. However, this is sort of, this kind of mushes together all of the children of different ages, and it's not quite clear when their immunizations were actually due. So we'll get to this, the analysis by cohort. But overall, the point of this slide is that 80% of patients, that immunizations have been happening in the last few months. And additionally, our surveys find that 80% of households reported that they had had some contact with the ASHA and antibody worker, or ANM, since the lockdown. 35% of them had it within the last month. And also amongst those patients that I told you, households that I told you reported missing an immunization, about 24% of them said they were able to get it. So to understand exactly, the effects of the lockdown, we now kind of look at things by cohort. So this is a series of graphs by cohorts. Or, sort of each graph is for a cohort that turned 9 months in that graph. So starting with January here, this is, the date of last immunization for children that turned 9 months in January 2020. And what you see, the sort of blue bar, indicates that a lot of these children came in January. And so why do we focus on 9 months is because, after the first sort of set of immunizations that are mostly due at early ages, children are due their measles immunization at between 9 and 12 months. And now, of course, not every child gets their immunization exactly on the date that it's due, or, but what we see is that most of them actually do. So most of the kids that were due, that turned 9 months in January 2020 actually came in January 2020, but some also, notice that some also come in February and March. And then there's an uptick in July because this is, these children are now due for their next immunization at 16 months. Moving on to February, again, you see that the vast majority of children who turned 9 in February did come in for their last immunization in February, and then it sort of tapers off. Some of these children keep coming in the sort of subsequent months. When you see in March, it still is true that most of the 9 months of kids who turned 9 months in March come in March, but look at the distribution is much flatter. There are fewer kids came in March than we would have expected based on the previous 2 months. And keep in mind, the lockdown happened at the very end of March. So it suggests this is probably because many children were immunized before the lockdown. What you see in April is, way lower, far fewer kids that were due in April actually came in April. Again, keep in mind, this is not a number of kids, this is a distribution of their, sort of the date of their last month. But what you see is that kids who turned 9 months in April did not come in April very much, but what's interesting is many of them actually came in May and June in the sort of subsequent months. Again, it's a very similar story for May. Children who came in May, who were due in May didn't come in May as much, but there is some sign that they came in June and July. And it looks like, so children due in April seem to have come a bit more in May. Children due in May seem to have come a bit more in June. And then in June 2020, it sort of looks like it's roughly back to normal. The vast majority of kids who were due in June, in fact, came in June. But keep in mind that we only have data through the end of July. What this overall suggests is that, kids the vast majority of kids that are due there come for their immunization on the month that they're due in usual circumstances. It looks like there were, that between March and May especially, there was a big drop in immunizations and delays. Children who were due those immunizations in those months did not come until later. However, it looks like those, as I just said, those children did come in a little bit later, so there's some suggestive evidence of catch-up. And by June 2020, it looks like things are, like a lot of children are coming in. So this is, like I said, this is the sort of distribution. Let's turn to what does this mean for actual immunization rates. And so this is sort of the share of children that turned 1 year old in each month. This is the share of those children that have been fully immunized on their Mamta card. And what you see is that the cohorts who turned 12 months old in January or February, who were really largely unaffected by the lockdown, have relatively high full immunization rates at 80-ish%. Children who turned 12 months between March, April, and May there's a perceptible decrease in their full immunization status. And then, there seems to be an increase again for children who came in June, who turned 12 months in June and July. And so keep in mind, this is their immunization status as of now, but by the month in which they turned 1 year old. And what it kind of suggests is that, despite the fact that children are coming in, maybe they didn't get it on their 9th birthday, but they're coming in a little bit later. Even so, it seems, so there is some catch up. Even so, that catch-up seems to be far from complete as of now. However, we sort of also acknowledge that there is substantial catch-up. And the other thing to sort of keep in mind is we're collecting data in August. It's likely that the catch-up efforts are sort of continuing. And so it's possible to some extent that these March, April, May kids will get immunized. But the fact that March, April, May is low and June, July goes back up, really sort of suggests that some of these kids just kind of got left behind, which is, if you think of both from the household and the ASHA side, like it's easy to remember kids who turn 9 that their immunization is due now, but the longer you wait for the sort of catch up, the harder it is to keep track of which kids are still due their immunization. And so this data at this point, we don't have all that many children, and so I'm just showing you the Mamta card results. You may be concerned that the Mamta card is not totally accurate, but the self-reported immunization status is a little bit noisier than this. We have fewer children, but shows very similar patterns. So the summary of results, I think for dialysis, we find substantial disruptions to care, big uptick in mortality, no similar uptake in historical cohort. Very strong evidence that this uptick in mortality is due to the disruptions in care caused by the lockdown. Immunizations, from the preliminary results that we have so far, it looks like there were disruptions to immunizations, and in particular, cohorts that turned 9 months between March and May, who were due their last immunization, were clearly delayed. There was some catch up in May and June and July. However, it looks like cohorts who turned, there's a substantial, children who turned 1 year during the months of the worst part of the lockdown still are much less likely to have their full immunization as of August. And so the catch-up is far from complete at this point. And the lockdown, after the worst parts of it, after the national lockdown, it sort of moved to a more staggered district targeted lockdown. And so ongoing analysis is going to look at whether we see different effects by district. Okay, I think sort of to summarize, it's very clear that the lockdown COVID was unprecedented. The lockdown was announced at a time when no one was clear on what to do, but I think our results really sort of show that care needs to be taken to ensuring that especially critical and chronic, critical chronic care and emergency care and routine sort of basic preventive healthcare services need to be sustained during any sort of alongside COVID containment efforts. All right, thanks very much. I'm gonna stop sharing my screen.
Wonderful, thank you so much. This was a lot of questions were generated. This is really interesting. I think both of you should feel free to weigh in. Not surprisingly, given human nature, we saw more questions around the second half of the presentation as people began to get into it and reflect. But a lot of the questions could actually be handled by either person, honestly, because there's a lot of interesting kind of interpretive things. Maybe just to start, just lob one or two at you, and then we can kind of start grouping them. But just to start, there were a couple of questions around access. One question was around, do you have any data or reflections on whether scheduled casts had different access than others to services? And another one about how you were capturing gender differentials across the range of presentations you were doing. There was some gender disaggregation here, but that was a question that came up. So can I pause there and let both of you grapple with just these basic access questions, and then we can get into another set?
Sure. So on the access to the, there are two parts to that question for access to lower caste groups. One is there access, even pre-lockdown, is their access always worse? And the second is, would it have been changed more by the lockdown? And so it's very hard. We haven't looked at access, whether it's very hard for us to know whether hospitals that are closer to where SCSDs reside were more affected by the lockdown. But for the most part, the lockdown was statewide, and it's likely that all hospitals, many of the hospitals that we interviewed were all over the state and all reported similar lockdowns. I think whether there's less access for SCSDs pre-lockdown, I think there almost certainly is. I think there are fewer hospitals in areas that are served by SCSDs generally, but I don't think that was just differential necessarily due to the lockdown. On the gender differentials, I think I'm not sure if I totally understood the question, but I think we asked.
Radhika, I think the question is, so we showed already in the dialysis results that the excess mortality is higher for female patients. I think the question was for immunization. We didn't show the results disaggregated by gender.
Yeah. So immunization, we specifically kept the results very minimal today because we don't have complete data, and I don't want to make, we don't want to make really strong claims until we feel confident that our sort of sample is complete. So I haven't yet looked at the gender differences, but that's a good point to look into. Stay tuned for the paper when it's ready.
Pascaline, any additions, any reflections that you'd like to add to that?
Just one comment, which is that in the claims data itself, we actually do not know the socioeconomic characteristics of the individuals. We know that they have a biometric card by construction because that's how you're eligible for the scheme. We know their gender and their age, but that's it. So we don't know their caste in particular. So that means that we can only do analysis based on caste when we are able to do phone surveys. So that limits, that's one of the limitations of just having, when you just have the claims data.
Okay, very good, thank you. I'm actually zinging around a little bit between questions to go low and then go high and then go low again, as it were, from sort of detail to broad. So there was one question that I think reflects on both of your presentations. It could be either on the COVID work or on the health insurance work. And it was really a question about, have you used these findings or do you anticipate using them for a more structured kind of policy and practice dialogue with partners in state government or others?
So I'm happy to take that. And just for clarification, this is just one presentation. we did it together. It's just that we tag team on who was speaking, but we think of it as just one presentation. And it's like the same work in some sense because we use the insurance claims to identify the COVID sample. But yeah, so we've been, this been collaborative work with the health department. So we've been meeting with the health department at the GOR, I would say every 6 months or 12 months, depending on when we had like a newer resource, and sharing our findings. There's, as you know, reshuffling in departments in Indian administration on a regular basis, and so there was just a change very recently, and so we are yet to meet the new team. They couldn't make it to this presentation, but obviously we'll be sharing all of this with them shortly. So we've been we put together a report back in December with a lot of the findings we've had ever since we had started. So that was a comprehensive report. Obviously, the ability of the government to immediately act upon these results was curtailed by the COVID-19 crisis. Their attention moved quickly to this, pressing issues, and they've sought our help in thinking through how to better understand some of the data that's coming in on mortality among COVID patients, trying to think about what comorbidities matter in their context. So we've been discussing with them the type of data that they can look at and use for that. So that's been the extent of the dialogue. And if you want me to put my finger on a specific change in the policy that is related to our work, that's going to be harder for me, which I would be happy to spend time lamenting on, but I don't think that would be a constructive use of my time.
Great, thank you. Any additions?
Yes.
No? Okay. Okay, that's really interesting. Yeah, I mean, I would also just say that the that linear kind of evidence to policy is often talked about, rarely done. Usually we see change coming from there's a kind of a policy change is not a linear process, and a lot of things have to happen, and progress is more often iterative than transformational, frankly. So, this is part of that larger process is what I would imagine. There is a couple of interesting questions. One question which I would actually like to expand, if you don't mind, a little bit, which is somebody asked, well, could mortality rates also just be due to people who are much more vulnerable, like people who get dialysis, to dying at much greater rates from COVID itself? Okay. And I wanted to expand that maybe to both of you to say, okay, that's a direct question, but also if you think about other confounders that are really challenging in this kind of work, if you could reflect on a couple of those. I'm sure you've talked about them endlessly among yourselves, because that would be interesting for you to surface for the audience. What confounders have you confronted, questions you really can't address through the existing data, but that would be really, really important to kind of begin to get a handle on?
On the mortality with due to COVID itself, we actually included direct questions about both about COVID symptoms, but which there are lots of fever and things like that, so that's not so helpful. But also COVID tests in the household, and they it's a very, very, very small, like below 1% of households said anything like that. So I don't think, I think this really is mostly about, and essentially we confirmed whether the death was due to kidney related problems. On the sort of confounders, I mean, one thing, it's very clear that there was a range of disruptions, and that it, and we sort of lump them all together and find that they seem to be associated with greater mortality. We can't disentangle what the sort of, even the sort of qualitative things I was reading out, people are losing jobs, and as a result of that, they're not getting food. People are stressed out. There's, in addition to the direct sort of travel barriers, not being able to get medicines, if they're, if they're switching hospitals, do they end up going to worse quality hospitals because the hospitals are understaffed? Are they getting poorer quality care even at the same hospital? So we can't really disentangle all of these things in the specific sort of mechanisms, but that contributed to the excess mortality. We kind of lump them all together, and it's very clear that they contributed, and they're all sort of directly or indirectly related to the lockdown. But we can't, we can't totally disentangle the channels for that. And I think the other thing that I sort of mentioned very explicitly is, which is related to my second point, is these startling sort of increases in mortality that we see amongst females. And there, even the stuff that we, the care disruptions that we directly measure, we don't find them that they that they're reported more by households with female patients. And so it's sort of a puzzle, what exactly is, I think mortality, the nice thing about mortality is it's such a clear outcome. It's so straightforward to report. So I don't think we have any concern that that effect is not real, but, what was it about the lockdown that particularly affected women is sort of this question. Pascaline, maybe you have something to add?
Yeah, actually, I just wanted to mention a few things. One is that the pattern we see that Radhika showed in the mortality. There's a spike in May, and then it starts. It seems like it's going back down in July, although our data is still a bit incomplete there, so it may still go up. But that pattern suggests that definitely at least part of the increase in May is due to the lockdown. Because if it were just due to COVID deaths and or like increased susceptibility, then you would expect the patterns to keep going, because the spread of the disease kept increasing, as you know. And so over time, you will see more and more of COVID-19 related deaths, and that's not what we seem to see. So we think that part of this, for sure, should be attributed to the lockdown. And then, in fact, there is a study that one of the participants very kindly just mentioned to me, a Lancet study that uses data from a cohort study that estimates 0.06% excess mortality for dialysis patients. I just looked at it very quickly in the last 5 minutes. So, but that's excess mortality in context where disruptions in care are much less than in the context we're looking at. So if we think of that as maybe a benchmark, we have a 1.7% percentage points increase. So it's almost like 3 times as much as what has been seen in context where disruptions to care were not the issue. It was more the susceptibility. So that's just to give a benchmark of what could be the main factors, and we strongly feel like at least a good share of the impact is due to the restrictions themselves. When we're on this topic, I just wanted to address one issue that was raised, which is about the harvesting, which is someone mentioned, well, maybe the excess mortality in May and June, people would have died anyway in August, and so the loss is still very very distressful, but it's a loss of a few months of life and not a few years of life. And obviously that's something that we can only speak to once we have done a much longer term follow-up. And so we'll keep looking at this data. So far, we don't find that there's a dip in death in July compared to the trend. If anything, it's still, for women, it's still higher. So definitely it's excess mortality that's for, not just bringing this forward by a month or two. It's at least more than that. But over time, we hope to be able to do more data collection to really document the extent to which this excess mortality affected folks who had no reason to die otherwise.
Yeah, I think on that, the results by age also show that it's like, it's dramatically, the younger people who are really affected by the lockdown. A lot of the, these are people that who should be sort of, some share will die every month, and to some extent all dialysis, the mortality rate amongst dialysis patients in India is relatively high in general, but yeah, I think that the sort of striking jump in mortality amongst relatively young dialysis patients was really sort of in evidence that this is about the lockdown.
Okay, interesting. Yeah, no, and I mean, you can see the range of issues. Just if we could now go a little bit, dive down a little, the few different methods questions that came up. Sorry, I'm trying to read my own sloppy notes here, so apologies if I'm not getting it right, but I'm sure you'll interpret it into a better question. There were kind of three that are not quite related, but at least speak in different ways to methods that might be good to kind of, some are pretty straightforward. One is about the care index, how it was constructed, if somebody was interested in that. A very different question was around the ethics around personal data and follow-up questionnaires. I would assume that would include claims data and so on. And then a final one, which is almost binary, is may I see the questionnaire you used? So I think people would be very interested to see what the questionnaire looked like, or questionnaires. You know, this is not a single one. So let me stop there. You can both wrestle with those any way you'd like.
I'm happy to go straight into the ethics issue. I think it's an important question. Obviously, this type of research requires very mindful attention to this issue. The use of personally identified PII data with personal identifiers is always subject to ethical review, and this is all the more important that this is health data, which is important personal information. So we got, as mentioned was by Radhika in the presentation, we applied for ethical clearance from the Stanford IRB as well as the IRB at IFMR, and we have the data under, everything is encrypted. It's like strictly confidential, and when we call respondents, the setup through which the calls are made is such that the surveyors themselves who call the patients have no ability to keep track of the numbers or anything like that. So the phone data itself is protected, and obviously the health information is protected as well. But that's one reason why when you say can we see the survey, our answer is like obviously, and we're gonna we can email us and we can share our survey instrument with you tomorrow. But if you say can we see the data, then we'll be like no. I mean the claims data no, and the survey answers we would have to first de-identify them obviously before we can share that.
Oh, and I think you go ahead.
No, I was going to say, Radhika, if you want to address the disruptions of care index. Then,
yeah, so that's just a sort of principal component analysis. So we create dummies for several, for all of the different disruptions that, sort of measures of disruptions to your healthcare, like if you, the hospital was closed or refused service, or you had difficulty getting medicines, or I forget all of the components of it, whether you had to switch a hospital, whether you had a decrease in your visits in April relative to March. And so we create dummies for all of those and use a principal component analysis to get the first component.
Okay.
And then we standardize it over the sample so that you can kind of understand that every, things are in terms of standard deviations.
And you have offered for people to follow up. I'm sensing that could be the kind of thing that might generate some follow-up questions on your own.
Sure.
Email.
Okay. Sure, absolutely.
Okay. For the data nerds in the crowd, and there will be many.
We can show the code. We can show the codes too.
Okay. Yeah, got a very specialized audience here. If I could just group a few, luckily they came in at the same time, just a couple of immunization questions because they just came together. So it might be good to quickly go through them, or I'll just pick three just to make it shorter. Did you only look at measles for immunization? How do historical rates, I guess going back more than 1 year, compare with the immunization rates you are observing, if you had that data? And immunization by gender, yes, question mark.
Okay. Okay, well, I can start. So on measles ones, no, we got, so from the Mamta card, we got all of the immunizations to date that were recorded on the Mamta card. And if someone does not have a Mamta card, we asked about every immunization injection. So we separate out the oral because that's harder for people to report, but we ask about every injection that they've got since birth. So the reasons I focused on the injection that was due at 9 months is because, given where we are now, the sort of expected pattern for the it's exactly kids who were due, who turned 9 months during the lockdown that would, we would have expected to see affected, and sure enough, we see that they are. So that was sort of why we looked at measles. But the last graph that I showed was the share of full immunizations amongst children who had turned, children who are at least 12 months as of now. Historical immunization rates. So yeah, it's not something we've looked at yet. The immunization work is still very early stage. So I wouldn't be able to say for sure how our rates currently compare to historical rates. The only sort of broad available historical data would be from household surveys, sort of these population surveys like the NFHS, or actually maybe the most recent one is the NSS. And so, we can compare our aggregates to those, and we'll have a look at that for sure, especially by district. And then yes, by gender, it's absolutely something we want to look at. Given, I think right from the very beginning, what Pascaline was talking about, we're both very interested in looking at sort of gender inequalities, potential gender inequalities in healthcare and healthcare seeking. So that's definitely something we want to look into.
Okay, very good, thank you. One more, we have a little bit more time, and there's a kind of an endless series of questions. So apologies to anybody whose question I'm not asking. I'm just trying to group and find the ones where there seems to be a predominance of issues emerging. There was one around nice correlation, picking up correlation between claims and mortality. Follow-up is the nature of the hospitals. Are these district, sub-district, state level? Where the level we're looking at? And any thoughts on how much higher the mortality might be for rural areas, given that about 2/3 of India's population is rural?
So the hospitals so for dialysis is sort of a specialty service and tends to be provided by much larger hospitals. I think many, but not all public district hospitals some public district hospitals provide it. So that's, at the district level. Almost certainly dialysis hospitals are not at the sub-district level. If the majority are in and around Jaipur or the big cities, but then otherwise they'll be at the district headquarters. But as I said, we sampled the universe. All patients that got any dialysis under the government health insurance program were sampled in our sample. Sorry, what was the second question about?
The India higher mortality rates for rural, given that 2/3 of India's population is rural.
Yeah, we did look at that. We didn't find, the sample seemed to be too small we didn't find big differences by urban and rural status when we looked at it.
Okay.
Yeah.
Any thoughts? Okay, we're gonna, unfortunately, this is actually the very exceptional webinar that may actually not only end on time, but have been given a lot of time for questions and answers, so that's great. If I might, I would just like to kind of ask one much broader question to give you guys a chance to step back and reflect a little bit. Given the work you've been doing, it's not only in the last few months, obviously, this is, there's been quite a long-term engagement. Observing the system beforehand, the strengths or emergent strengths and the weaknesses, which I think we all are aware of, and the response to COVID, what impressions or thoughts at this point, it can just be reflections, do you have on areas in which the system demonstrated perhaps more resilience than you might have expected? If somebody had, not knowing that this crisis was going to occur, and areas in which it really did not demonstrate the resilience that one might have hoped, even with kind of limited endowments. That would be, so for both of you, be good to get some thoughts.
So let me start. It's a tough question, but I think we see very different. The pictures we painted is very different if we look at the dialysis versus the immunization. And I think we are really talking about two different systems here. One is the system of primary health care delivery, and especially the ASHAs, and the work that they do, and the immunization campaigns during village monthly immunization days, and that seems to be quite resilient. I mean, during the lockdown, it kind of stopped, but then it seems to have really picked up quickly after that, based on the data we see. And one of the audience participants just mentioned in a Q&A that apparently there is new HMIS data that was released today, and so we will be able to look at that and see whether that data confirms what we find, or whether what we find suggests that the HMIS data is still incomplete. We'll see. But on the whole, we were very excited to see the catch up in the immunization, and to see that the disruptions in April and really do not seem to lead to large, long-lasting gaps in immunization, and it may well be that delaying immunization by a month or two has no impact on later health outcomes. And so that shows really a kind of like strong system of making sure the households get access to care. And in fact, I think, I don't know if Relika showed that, I don't remember, but we do find that most of the households we talked to in the last month report having had contact with a health worker at that level. So that's very encouraging. Now, the dialysis results, that's really shows that the hospitals themselves were kind of like struggling to provide care. There was part of the disruption definitely was people not being able to travel to the hospital, but some of the disruption is really people not being able to access their care when they get to the hospital. And we also did a qualitative interviews with hospitals in parallel to the phone surveys with patients, and we heard a number of hospitals inform us that they were struggling because the health workers couldn't come to the hospital, or they had to how to deal with like COVID patients versus not COVID patients was complicated. And that's maybe the area where I would think crisis preparedness could have been stronger. But I let Radhika comment if she wants to add anything.
Yeah, I think, I was going to say the same thing about the sort of the health workers, but I think sort of extrapolating a bit more generally from that is, a lot of the work that Pascaline and I have done is looking at sort of public sector and private sector participation in the health system. And it's a sort of more general thing I'm interested in. And I think that, in India, sometimes the conversations around public or private get very sort of polarized, and it's one is good or one is bad. But I think one thing that, in past work, we found that often people much prefer going to the private sector at the hospital level. People prefer private hospitals. There's some evidence that private hospitals, provide some slightly better care. There's certainly, it's certainly private hospitals are a very large share of the overall insurance system, insurance program. And so they're a very important part of the sort of health system. But, it was sort of interesting during a time of crisis, the private sort of players were, as Pascaline said, they themselves were really affected by the lockdown, but also it's a little harder for the government to sort of call on them to mandate them to do things. And so, what the frontline health workers, part of the catch-up that we saw was, explicitly the government said they were going to go on catch-up immunization drives, and they can call the health workers and say, now there's a whole additional debate there. I know that the health work ASHAs have sort of gone on strike because they feel like they're not being paid enough, so there's all of that. But the point is that to some extent in a moment of crisis like this, these sort of resources in the public sector are available to the government in a way that the private sector isn't necessarily, unless the government builds a much stronger relationship with the private sector. And sort of similarly, we don't have this is just sort of anecdotal based on the qualitative responses we saw, is that, as the private sector was collapsing, a lot of people, the government hospitals tended to stay open, probably because the government made more of an effort to make sure they were able to stay open. But, so people switched to public hospitals. That's not an unequivocally good thing. People still died. Maybe the care at the public hospitals isn't as good as anyone who's gone to a public hospital in more remote areas knows the quality isn't great. But I just think that, at times of crisis like this, the public sector can play a really important role. And right. I think it sort of points to I think the private sector is here to stay in India, but strengthening the public sector, I'm sort of maybe not so economist, but that I really think strengthening the public sector is an important part of the overall health system, and it sort of competes with the private sector.
Right. Okay. Thank you very much. I think that was great. My sincere apologies to those who did not, whose questions were not posed, and that's on me. So I'll take all the blame. We did run out of time. They were a great set of questions. This was a really, really stimulating event. It's obviously not the end of this road, right? I don't think your work is done, and certainly not our work is not done. But this was really, really a great input and a great, great event. Really, it's making me think a lot. I'll put it that way. So just huge, huge thanks to both presenters. Urvashi, would you like to say any closing words of wisdom?
So thank you everyone for joining, and I know it's very late here in India. We're going to close the webinar now, but there'll be a feedback form that you might get right afterwards. So please do fill it out. We'd love to hear what you thought of the session. Thank you.
Thank you, everybody. Thank you, Stefan.
Thank you.